Okay, let's talk about heart disease now in a conventional sense. How conventional doctors look at that disease forming in the body. And then we're going to dip into your alternative view on the real cause.
Yeah, I think that the conventional view is still, guideline bodies still say that LDL cholesterol is a primary causative risk factor for heart disease. But I'm coming here and saying, at best, it's a weak risk factor. At worst, it's not a risk factor at all. So that's quite a jump, right? So what my research, what other people's research has shown, extensive research, not just based upon cherry picking one bit of data. It's like looking at the totality of evidence, right? It's not about selective reporting. I think the people who are pushing this narrative have engaged in selective reporting because of ideology, because of a fixed view. We've got to remember, you know, certainly amongst medicine, unfortunately, changing one's mind can be quite difficult, even though it's part of evolving science and good practice. Just because we're human beings, that's part of being human. But what actually is at the root of heart disease, which is not being challenged, it's just there's no market for the message, is insulin resistance. Essentially, your body becoming resistant to the hormone insulin over time, which we know through different mechanisms is directly, chronically raised insulin is directly toxic to the inner lining of the coronary arteries, which is how heart disease develops, the furring of the arteries, this so-called plaque buildup, these fatty deposits of immune cells and cholesterol, which are likely arriving there as a response to injury, not as the cause of the injury, and therefore building up these pimples or whatever you want to best to describe it for a layperson within the inner lining of the artery. And insulin resistance drives that. And probably, responsible, I think, certainly some studies suggest that in 86% of people, some degree of insulin resistance, who've had heart attacks, some degree of insulin resistance is there. And therefore, the approach should be to try and manage the insulin resistance. But from a drug perspective, no drug has really been developed to show improved outcomes with that. But there is a lifestyle approach, which we know is effective. And that's basically the very simple way of putting it is a low-carb diet. Low-carb diet is the best proven dietary intervention, any lifestyle intervention actually, to rapidly improve markers of insulin resistance, which include basically blood pressure, glucose through HbA1c, which is a marker of prediabetes or type 2 diabetes. Two markers of the cholesterol profile, which I think are reflective of insulin resistance. Those are triglycerides and HDL. So you want triglycerides to be low, HDL to be high, so-called good cholesterol. And waist circumference. And that's your belly fat and your visceral fat. And if all of those are in the normal range, you have minimum insulin resistance, if not normal in levels of you're not insulin resistant. And it's called optimal metabolic health. And 93% of adult Americans now, Jesse, have suboptimal metabolic health. And what's interesting about metabolic health is it isn't just the main driver of heart disease. It's also, after smoking, the main driver of cancer, and also the most important risk for developing Alzheimer's disease as well. So it's important. That's what we should really be focusing on with lifestyle. And I think if we do that, we'll get better outcomes. Now, why am I not guaranteeing better outcomes and saying it's most likely? Is because we don't have the highest quality level of evidence in terms of randomized controlled trial data saying that we'd intervened on insulin resistance and we follow those people up. That hasn't been done, as far as I know. It might be studies ongoing, because obviously that needs funding, et cetera, et cetera. So who's going to profit from that? To tell people to avoid ultra-processed food and sugar, eat steak and vegetables and, improve your gut microbiome. Who's going to benefit from that financially? So there's no, this is part of screwed up corporate capitalist system, unfortunately. It's medical knowledge is under commercial control, but most doctors don't know that. And that knowledge base amongst doctors is coming from people producing products to sell you, essentially.
So if we zoom in on the vessel, you mentioned insulin resistance.
Yes.
So we have elevated blood glucose,
Yes.
causes elevated insulin.
Yeah.
When it comes to that micro damage in the vessel, is it both of those that are causing it?
Great question. Probably yes. Interestingly, when I did my research during COVID, because I wrote a book called The 21-Day Immunity Plan, and I did a lot of work being an advocate to try and understand what were the lifestyle risk factors for COVID. One of the most interesting papers I found, which again is mechanistic, but it's interesting, is that one high starch or glucose meal or sugary meal, independently of, so raised insulin and glucose, independently they affected markers of clotting. So glucose raised on its own without raised insulin interferes with clotting in an adverse way, because it increases the clottability of the blood. And the same thing happens with raised insulin. So I think it's probably both. There are multiple mechanisms. Insulin, for example, raised insulin will cause the first cell to be affected on the inner lining of the arteries. Is called the endothelial cell. So dysfunction of the endothelial cell, which produces something called nitric oxide, which helps dilate the vessel. And if the vessels are not able to expand or dilate, they're also more likely to get stiff and more likely to get damaged. The endothelial dysfunction is the beginning of coronary artery disease developing. And those are those things you've talked about, including smoking, including chronic stress, which we'll come on to. The other interesting thing that a lot of people don't know about, Jesse, is this clogged pipe hypothesis. Is they think that heart disease is gradually progressive over time, and then it becomes and over time it becomes completely blocked, and then you have a heart attack. That isn't actually what happens. Number one, it's not chronically progressive necessarily. It's dynamic and it can reverse, which I'll explain a little bit later. So please remind me about that. But the other interesting thing is most heart attacks happen at blockages that are not severely narrowed. A severe narrowing is considered about 70% blocked. That's physiological. That when the demand on the heart muscle increases from, say, exercise, that's when the blood supply doesn't meet the demands of the heart muscle in terms of oxygenation, when the vessel is more than 70% blocked. And that's when people get what we call angina, chest pain. But the blockages that are likely to rupture, like pimples bursting, and cause a complete blockage, which causes a heart attack, where the blood supply is completely reduced for several minutes, and then you get damage to the heart muscle, which is a heart attack essentially. 86% of those plaque rupture causing the heart attack happen at blockages that are less than 70%. And that's probably one of the main reasons why heart stents, and I trained as an interventional cardiologist, essentially keyhole heart surgery, putting in these little metal scaffolds and expanding them in the artery where the blockages are, okay? Those stents do not prevent heart attacks in people who have what we call stable disease, stable angina. So blockages over 70, 80, 90%. Because one, that blockage that's 90% is not the most likely to cause a heart attack. Two, you're disrupting the vessel when you actually put the stent in, and that causes a heart attack in maybe 1% of people. And then you're not managing where another plaque, which might be 20 or 30%, and putting a stent in there doesn't do any benefit either anyway. You wouldn't do that because you're going to cause complications of the procedure overall if you start stenting people with a less significant blockage. And you don't know which one's going to rupture anyway, okay? Those are the plaques that cause the heart attacks. So what we need to do is, and this is what I've written about, is we institute a lifestyle approach which is likely to pacify all of those plaques and potentially reverse them and reduce the risk of a heart attack occurring.
Okay, so far what we have, insulin resistance causing the pimples in the vessel.
Yeah.
We can get rupture, more likely in the smaller ones. Do we know what actually triggers that rupture?
We don't. It's like a ticking bomb. It's something that just builds up over time. But, things like stress can trigger it, for sure. A lot of people suffer a heart attack after a life event. So it could be that there's just, and then suddenly a stressful event. A high carb sugary meal theoretically could, as we've talked about, increasing the clottability of the blood, right? So I think those are the kind of things that will trigger it, for sure.
One of the things the body does as it incurs blockages is forms collaterals. Talk about this safety mechanism that our body uses.
Yeah, so actually it's a great point because, as I talked about earlier, there was a thinking that these clogged pipes develop over time and then you get 100% blockage and then you get a heart attack. That rarely happens if it's increasing slowly. If that blockage is occurring over time slowly and it doesn't rupture, it becomes a stable plaque, what happens is the heart adapts and there are extra vessels that grow to bypass that blockage. And I've done angiograms in patients, for example, that have got a complete, no heart attack, a complete blockage of one of their three major arteries. There are three major sort of arteries, the left anterior descending, the circumflex, and the right coronary artery. And I've seen people with right coronary arteries completely blocked, but the left anterior descending has got an extension to it that overcomes the blockage to the right coronary artery. And those are collateral vessels. And that's fascinating to see. So it probably gives some protection to those people. But you can't predict necessarily. We don't know how do you increase collateral flow, but it's like an adaptation mechanism for some people. The key thing is to avoid heart disease in the first place and then potentially reverse it or manage the risks.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
I trained as an interventional cardiologist. I love solving puzzles. When you've eliminated the impossible, whatever remains, however improbable, must be the truth. Guideline bodies still say that LDL cholesterol is the primary causative risk factor for heart disease.